Hello, my name is Chibikem Uche,
And I'm Parker Hamilton.
and we decided to focus our potential solution to solving a healthcare problem across the globe on combating malaria for children in sub-Saharan Africa, specifically children under the age of 5. We decided to focus on 4 specific countries: Nigeria, the Democratic Republic of the Congo, the United Republic of Tanzania, and Mozambique. Because in each of these 4 countries, they represent just over half of all malaria deaths worldwide, specifically under the children under the age of 5. This is an incredibly daunting issue, and it's important for us to address. And we hope to address this issue throughout our presentation and offer a clear and coherent solution that is one specific and nuanced to address this problem of malaria for children in sub-Saharan Africa. So let's begin by understanding what malaria truly really is. Malaria is a life-threatening disease caused by parasites that are transmitted to people through the bites of the infected female Anopheles mosquitoes. It is both preventable and curable. We need to keep that in mind as we go further and further along our presentation. In 2020 alone, there were an estimated 241 million cases of malaria worldwide, and the estimated number of malaria deaths stood at 627,000 in 2020 alone. So if we make our attention to the graphic to the right, I want to pose how big of an issue this is in sub-Saharan Africa alone. First, let's look at this graphic right here. The blue represents malaria transmission is not known to occur, right? The yellow represents in countries and areas where malaria transmission occurs. In some places, it's not as big of an issue. The orange and red represents where malaria transmission occurs throughout and is an incredibly daunting challenge and issue for that region. And if we look at the graphic, if we look at the United States, South America, other parts of Asia, Europe, and if we look at even Australia as well, we can see that none of these places have a big issue with malaria. But if we look at this red area, the only parts that have red are in sub-Saharan Africa. And that just underscores how big of an issue malaria is, specifically in this region, and specifically for children under the age of 5. And if we look at this graphic below as well, it just underscores how big of an issue malaria has been, specifically in sub-Saharan Africa. If we look at deaths from malaria, it just shows it right here, and it shows you specifically how it's impacting children at a disproportionate rate if we look at this graphic right here. So with that, let's go back to our presentation. According to the World Health Report in 2020, sub-Saharan Africa accounted for approximately 95% of malaria cases and 96% of malaria deaths, and children under the age of 5 accounted for an estimated 80% of all malaria deaths in the region. 4 African countries that I stated before: Nigeria at 32%, the Democratic Republic of Congo at around 13%, the United Republic of Tanzania at 4%, and Mozambique at roughly 3.8%, represented over half of all malaria deaths worldwide. And this is going to be incredibly important to know as we go further in our presentation. So, to discuss more about it, if malaria is diagnosed and early and treated, it can actually be cured in about 2 weeks. Those living in remote and insecure areas, however, with little or no healthcare access, face daunting challenges to receive treatment for malaria. And many people who live in areas where malaria is common can get repeated infections. Children sometimes face up to 13 episodes of malaria a year and never really recover between episodes of illness. And without treatment, the disease can be fatal, especially in children who are malnourished. And a child is killed by malaria every 2 minutes. And it disproportionately affects children under the age of 5. And we can see that from this graphic to the right, just how important of an issue malaria is, and how 67%, 274,000 deaths of malaria occurred worldwide in children under the age of 5 years. And that is an incredibly important issue that we need to address and must be addressed globally, specifically in sub-Saharan Africa.
So our solution to this problem is a 2-part approach. We want to create pop-up clinics and mobile clinics to combat malaria while also providing a training program for locals to integrate this treatment into their own society and carry this program even further. So we're looking at the model done with COVID-19 in the United States recently, which was very efficient and quickly implemented. And we hope to expand to other countries if this is successful. We want to provide the typical malaria medications such as chloroquine and doxycycline, as well as the newly developed RTS vaccine, Mosquirix, which is administered to children between 6 weeks and 17 months of age, which fits well in that target range of children we are trying to help save. By offering these multiple treatments, we'll help prevent monotherapy, which can lead to drug resistance in mosquitoes and the parasites they carry, and help the children develop partial immunity to malaria. We also want to distribute preventative measures from these clinics, including mosquito repellent with DEET and insecticide-treated mosquito netting. For the training program, we want to partner with nonprofit organizations like Medicines Sans Frontieres or Doctors Without Borders, and the African Medical and Research Foundation to help supply physicians and pediatricians that can teach these local people how to provide care while working and providing care themselves. These local citizens will learn from these nonprofit doctors while helping them provide malarial care to the children and eventually take over all of the operations in every country. On average, sub-Saharan countries have 0.216 physicians per 1,000 people, with a rate that is much lower in certain areas. That is an incredibly low number and something that needs to dramatically rise if we hope to prevent these illnesses throughout sub-Saharan Africa. By increasing the medical providers, it'll lessen the burden on dependence on foreign aid and help these countries improve life expectancy overall and life in general. So next, we want to turn to some evidence for the solution and why we think it would be effective. Specifically, we're looking at 2 examples from Kenya. On these previous successes of improving general medical care to remote African village, where it's difficult for traditional healthcare to supply treatment. So the first of these is a camel clinic. You can see from the picture on the top right. These groups consist of about 7 to 10 camels and a team of medical providers. They travel throughout the country and provide medical care treatment to roughly 30 to 80 people at each place before they move along. They travel in 2-week circuits, but that's only because they are limited by donor funding and cannot continuously do this throughout the entire year. The other example would be a motorbike ambulances, as seen in the bottom right. These are very maneuverable vehicles, which allow the delivery of medicine and transport of patients on roads that are impossible for other vehicles to travel on. And this program has been successful, yet funding also remains an issue. So as you can see, these examples have had success, but the scope they're currently operating in is very limited, as they don't have the required funding necessary to get the medical treatment to everyone who needs it. And by expanding into our program, we can work to reach those people who are unable to receive treatment at the moment.
So in order to further understand how big of an issue malaria is, we decided to include a personal anecdote and a personal account, a cautionary tale from the Adissa family and their deal with malaria. So we'd like to present some context about a family who the parents were Fatai and Hana Adissa, and their baby Miriam. They moved from Nigeria to the United States about 10 years ago. And since then, when they went to Nigeria on a trip, they had grown to 5 children ages 2 to 11. Over several weeks, they traveled to many parts of Nigeria, such as Lagos, Abuja, Kano, and Lorin. And after their trip, they all returned back to Indiana in late January in roughly 2006. And the 4 older children, they went back to school. They felt like they had no issues, no problem. But however, 2 weeks later, they began to have fever, headaches, and flu-like symptoms. And the issue was they decided to go to the hospital. And after that, prior to going to the hospital, they tried to do preventative care, taking antibiotics and other issues. They tried to do certain flu shots, certain different things, which is going to be very important as we discuss how much of an issue access is to care for children specifically in malaria. And we're going to elaborate this on a little bit more. But at the end of their trip, they were misdiagnosed because they went back to school and they were misdiagnosed with the flu, but they're really suffering from malaria. Most fortunately, all 5 children recovered from this extraordinary ordeal. But within that, their children became very sick. By the 7th day following their hospitalization, all 5 children have been discharged from the hospital, well recovered and free of malaria. Now, the important thing to address by this situation is, 1, this family took preventative measures so the children would not get sick, yet the children got sick. 2, after a couple weeks, around 2 weeks of treatment, they returned back to the United States and they were still feeling really sick. And they were misdiagnosed with the flu, and they still had access to incredible doctors, incredible medical care, but yet they were still misdiagnosed. Thirdly, even after receiving medical care, it took a lot of medical treatment, access to a lot of important medical care and facilities in order to help these children recover and become free from malaria. This is incredibly important to understand. These children were diagnosed early. These children received treatment. These children were able to get access to medical care to help solve this issue of malaria. And as you can see, they were able to survive. They became back to normal. This is stuff right now that children in Africa, specifically under the age of 5, and in these 4 countries that we addressed, do not have access to. They don't have access to these specific doctors. They don't have access to healthcare. They don't have access to treatments to help them diagnose about malaria ahead of time. So they're constantly going under repeated cycles of infection. But with our solution, if we were to impose what we decide to do, we can address this issue and we can allow for children to have the same response that children like the Adissa family children had, where they're able to recover from this disease and are able to live life as they did before.
Next, I'd like to talk about funding, which, as I stated previously, has been a big issue for other similar concepts throughout Africa and disease prevention. So research shows that starting a mobile clinic costs between $300,000 and $2.5 million in Southern America. So we predict that our cost would likely be lower as we need less technology than modern American clinics and provide a variety of general care. So our goal is to provide 10 clinics per country, and we have 4 countries for 40 clinics throughout this program to start. We also want to provide malaria medication, and conventional treatment costs 10 cents to produce, and newer treatment costs up to $2.40 to produce. We hope to acquire these at these prices, but at most we'd like to just double them based on the markup by the producers. We also want to distribute preventative measures, including insecticide-treated bed netting and repellent containing DEET, which is $2 per net and $5 per can of repellent. As for staff, a comparable organization, Doctors Without Borders, starts field worker salaries at approximately $25,000 per year. And we want to start off between 5 and 10 workers at each clinic and start with 10 clinics. In terms of training, there's no additional cost needed to provide training, as those providing the actual care will be teaching while on the job. And this training will be both international and local individuals. So the total estimate from all 5 of these facets is roughly $29.8 million per year for all clinics. And after this, we hope to expand into new countries and add more clinics within the countries we've been working in. There are also a few obstacles, but we have refutations to them in terms of this. One of those would be the funding sources. Many sub-Saharan countries have low GDP and overall wealth, so payment will need to initially come from other sources. We propose that this be paid by international organizations like the World Health Organization and private donations. But as this becomes more successful and life expectancy improves overall, the payment will be phased to the beneficiary nations as malaria declines and life improves. Another would be the staff. Competent medical providers are needed to start the program and teach the locals how to increase prevention and administer treatment. So we'll also need a large number of local citizens as well to take over these clinics as their number and locations expand. But we expect many locals will be eager to help eradicate this horrible problem they all face in sub-Saharan Africa. The third obstacle would be armed conflict. Our target countries have certain areas of active conflict that can make providing treatment dangerous and disincentivize people from wanting to work in those specific areas. However, research shows that armed groups usually don't interfere with groups preventing diseases because they themselves have been affected by the diseases and benefit from them as well. In terms of feasibility, political factors, probably all affiliations would give support because they would not want to be seen as preventing the spread of malaria, especially since the costs are moderately low and this program targets children. Additionally, the leaders of Nigeria, the Democratic Republic of the Congo, Tanzania, are all accepting of the foreign aid for HIV and AIDS through PEPFAR, and they would likely accept help with malaria too. The only caveat to this is Mozambique's president, Felipe Nyusi, has been strict on some foreign aid in the past, but recently he's opened up to more intervention, making this proposal more feasible.
So to elaborate on the feasibility, specifically the social factors, clinics would help serve more patients by being inexpensive and more accessible than traditional hospitals and other medical facilities. And to elaborate on that, it would most likely be welcomed by nearly everyone in Africa, because as it is a continental issue. As we said before, malaria has impacted sub-Saharan Africa at an incredibly disproportionate level, and any sort of aid, any sort of benefit that they can get would be incredibly beneficial to help their family and loved ones. And a vast majority of Americans and people in other countries would support giving aid in order to address this incredibly daunting issue. So that concludes our presentation, and we would like to end with a message, and one of optimism and one of potential hope with our solution. And we all have the end goal, and one that we should all share, which is we want to end malaria for good. Thank you so much, and I hope you enjoyed our presentation.
Thank you.